This is all about the pharmacoeconomic analysis models. There are two kinds. One is partial pharmacoeconomic analysis, one is complete. In partial, cost of illness or cost consequences, where we don't consider the outcomes or efficacy of a thing, like the amount of money that is spent to manage diabetes in a particular area over a particular period of time, just the cost of the illness or the cost consequences, like managing diabetes and its complications, how much is being spent is what is the cost of illness or cost consequences analysis. Now, in the complete pharmacoeconomic analysis, there are four methods: cost minimization, cost effectiveness, cost benefit, and cost utility analysis. We have to understand that this is a model which follows the ECHO type, like economic followed by clinical and humanistic outcomes. So ECHO, economic, clinical, uh, humanistic outcomes, ECHO type. And so there are four complete pharmacoeconomic analysis. Now, how to take up which type of analysis needs to be done? When there is a pharmacoeconomic problem, a prescription has come and we need to find out which is the best alternative or which is the therapy, whether home care is better or whether hospital care is better, whether a combination drug is better or individual drugs are better, combining an injectable for 7 days with a tablet is better or only injectable is better, like all those things. When we talk of any pharmacoeconomic problem, it starts over here. The find the least cost alternative first. If you are not finding any least cost alternative, then it is not a complete analysis. So it will fall under pharmacoeconomic analysis, that is partial in type. So we are just going to see only the cost of illness there. We are not going to talk about the outcomes. But when we are going to talk about outcomes, when the outcomes are going to be equivalent, now the cost is different, but the outcomes are equivalent, then that will follow cost minimization analysis. If you are not going to see the equivalent outcomes where the cost and the outcomes will all be different, then in that case, if the outcomes are not going to be equivalent, then it is not a equivalent outcome, then it is not a cost minimization. In cost minimization, the outcome remains the same, whereas the alternative drugs are different. So there we are going to see. But when the outcomes are not going to be equivalent, it will be either we have to do a cost effectiveness, cost benefit, or cost utility analysis. Now, cost of illness analysis, we know that it is just the illness cost to manage a particular disease. What is the cost? Cost minimization, we know that the outcome remains the same. Taken for granted that the outcome remains the same, the alternatives are different. And so, which alternative is less costly? That is cost minimization analysis. Now, cost effectiveness analysis, where we have to calculate two things: ACER, average cost effectiveness ratio, and incremental cost effectiveness ratio. Now, ACER is calculated by cost in rupees divided by clinical outcome, but the clinical outcome is not in rupees, it is the effectiveness. And incremental means the difference between cost of A and cost of B divided by effectiveness in terms of percentage of A, effectiveness percentage of B. So when we reduce this, we will be able to get the incremental cost effectiveness. So now when we talk about cost effectiveness analysis, we are literally talking about the net cost by the net effectiveness. Net effectiveness means avoided ADRs and other things will also be included in that. And net cost means whatever drugs, side effects, and non-compliance cost plus whatever is to be added. We have to talk about all these things. So that is cost effectiveness analysis. Next comes cost benefit analysis. Benefit cost ratio or benefit minus cost. This has to be calculated here. So the cost benefit ratio, benefit versus cost ratio, if it is going to be above 1, just reject it. When it is going to be equal to 1, you can consider. When the benefits are going to be more compared to the cost, more than 1, and then that is going to be okay. So benefit minus cost is one more way of checking the cost benefit analysis. The choose the alternative with the largest value possible over here. This. So whenever the value is bigger, that means that the benefits are higher compared to the cost. The last one is the CUA, cost utility analysis, where the quality adjusted life years are compared, like checked for a particular cost or for a particular therapy. So it is going to be 0 if there is death, it is going to be with zero point 0.5 if it is partial health, and it is going to be full health if it is going to be 1. Meaning, 1 quali means 1 full health year, and 2 3 years of partial health means 3 years of partial health is 1.5, because 3 into 0.5 gives you 1.5. Now, if this is just a comparison, like when the therapy is going to be similar and the outcomes are also going to be similar, therapy is similar but the cost is different. So the cost is compared with the clinical outcome, whereas the clinical outcome is considered to be fixed in CMA. In CMA, the cost is going to be different, whereas the outcome is considered to be fixed. Then we follow CMA. Now, if the therapies are different and the outcomes are different, where therapy is measured in terms of cost and the outcome is measured in terms of real disease units, then we follow cost effectiveness analysis. Right now, when there is a similar therapy and the cost is different, whereas the quality adjusted life years are differ between the therapies, then it will follow CUA. Right, so here what is checked is quality of life and patient preferences. In both these conditions, CUA will be applied. Now, when we talk about the different therapies or program and the outcomes are also different, but the therapy or the program as well as the outcome is all equated in terms of cost versus cost, then it is going to be benefit analysis. Now, when we talk about this, when we make a table of 3 by 3 or 4 by 4, and we track all this benefit versus cost, the criteria is very simple. Benefit is going to be high and the cost is going to be high. We can still evaluate that as a therapy. Now, benefit is going to be high, whereas the cost is same, we can accept it. When the cost is same as that of the older therapy and the benefit is higher for the newer therapy, we can accept it. When the benefit is going to be more and the cost is going to be less, we can accept the therapy. Right, the same way, benefit is same and the cost is high, then you need to reject the therapy. And when the benefit is same and the cost is also same, we need not take any action, or we can think whether to take it or not. Right, and when the benefit is same and the cost is less, then we can accept that. And when the benefit is low whereas the cost is high, you need to reject it. When the benefit is low, the cost is same, you can reject it. And when the benefit is low and the cost is also low, you can evaluate it. Right, so in PE research, we have to first fix up our objectives, then perspective, for which perspective you want to do the research. Like from the patient side, see, if you put a number 6 and see it from one side, it will look 6. You go to the other side and see it is going to be 9. So whether from the perspective of the patient, from the perspective of the provider, from the perspective of the insurance company, from the perspective of the community, from the perspective of the society, from which perspective, national perspective, like from which perspective you are going to see the problem, then the perspective, it will differ. You know what you have to find out, what design you will have to follow, what PE type you want to study. All these things will differ. We have to understand that all alternatives, all costs should be considered in any pharmacoeconomic analysis, and the discounts that are given, and the sensitivity analysis. Sensitivity analysis means there are certain intangible things for which we put a cost in cost benefit analysis, right? So when I change, like today, if I get an I'm losing money of 2000 rupees while undergoing a treatment because I am not able to attend a job. If it is 2000 rupees, what is the outcome? If it is 1500 rupees, what is the outcome? I am a daily wages worker where I get from 1000 to 2000 rupees. So if it is going to be 1000, what is the sensitivity? If it is going to be 2000, what is the sensitivity? All these things matters. And finally, we have to come to the conclusion. What are the limitations of pharmacoeconomic studies? Sample size is not that big. Randomization is a problem. You cannot randomize them to, control group, test group. Doing all these things is not possible really over here. Generalization is an issue. We don't know really for the intangible and the opportunity cost, what cost actually should be given in terms of rupee value. A value allocation is for the intangible elements are a limitation of the pharmacoeconomic studies. So this is just a summary of how and what a pharmacoeconomic study it is just a summary. It is not going to throw complete light on what it is, but then it is just a summary. Thank you.